I'm not going to spend a ton of time here through the electrical conduction system. Obviously, we have our SA node, you have your intraatrial pathways, and then it kind of goes down and ends up kind of holding up the message here at the AV node before it gets released down that right and left bundle. Remember that on the right and left bundle, though, we end up having other portions of that. So this left bundle branch block, for example, we have a left anterior fascicle, and we also have a left posterior fascicle, and those are all part of the left bundle itself. So bundle branch blocks can be a pre-existing condition. Individuals live with them, right and left bundle branch blocks, but they can also be brought on by an acute coronary syndrome. Where the problem comes in is a right bundle branch block. We can still read our EKG under normal conditions. So if you do an EKG and you think that your person has a right bundle branch block, you can still feel confident in calling in and telling the doc that you have a patient that's having a STEMI, for instance. If it is a left bundle branch block, you need to be a little bit more reserved on that. So the left bundle branch block makes it a little bit more difficult to interpret whether or not they are having an infarction. So you can either call in and say, hey, I have a left bundle branch block, so I'm not sure if they're having an infarction, or you can apply either Sgarbossa's or modified Sgarbossa's criteria to it to try to help you read through whether or not they are in fact having an infarction or not. So bundle branch block caused by an acute myocardial infarction, about 60 to 70% are associated with pump failure. So that left ventricle is not going to be able to pump out correctly. And about 40 to 60% have mortality without any type of reperfusion. So bundle branch blocks are not something to just blow off. If you have a patient that has a new onset bundle branch block, they need to be evaluated. So the bundle branch blocks are going to end up altering depolarization, and that ends up affecting the QRS. So when we are looking at QRS, and I did it kind of subtly before, go to V1, look at your V1 lead and look at your QRS width. If your QRS in V1 is wide, you're probably dealing with the bundle branch block, and then we can include some other diagnostic criteria to determine if it is a left or a right. Remember that your bundle branch blocks can mimic acute coronary syndrome, and it can also hide evidence of an acute coronary syndrome. So don't get tunnel vision here. Look, and if you have a bundle branch block, then you need to think for a second. The reason that we take time to talk about these is because they can mimic everything that looks like an MI, and it may hide everything that is an MI. So they can produce that elevation, depression, tall T waves, and it can hide all of those same things. And we don't want people to get caught not paying attention. So if you have a bundle branch block, please pay attention to it. Ask the patient if they've ever had it before. And if they say no or they're unsure, then treat it as a new bundle branch block and transport quickly to the appropriate facility. The problem here is we have to reperfuse. The patient with a bundle branch block that is produced by an acute coronary syndrome really needs to have either MONA or FONA, right? The fentanyl, oxygen, nitro, and aspirin. So acute coronary syndrome is harder to identify on an ECG when a bundle branch block is present, because it does throw that waveform off and it changes the width of that QRS complex. So we'll look at that. A new or presumably new bundle branch block is an indication for acute reperfusion therapy. So here's the deal. We don't have the luxury in the field of knowing whether it is new or old or getting an old EKG. The only way that you would know that is if you've made prior calls on that individual and you just remember what it looked like. Other than that, we take the patient in, we say, hey, we've got a patient that has a bundle branch block. The first thing that the doc is going to do is say, hey, can you call cardiology and see if they have an old EKG on file for this person? And if they get that EKG and they can compare them side by side and the patient had it before, probably not that big of a deal today. If they don't have one on file, this person has probably just got themselves a trip to a cath lab for reperfusion therapy, or at a minimum, they're going to end up starting them on some medication to try to reperfuse them, because it is a presumptive block until proven otherwise. So your right versus a left bundle branch block. We should use lead V1. So what we're looking at here is the terminal force or the terminal velocity. So we're always going to still go to that J point, and we back up 0.04 or one small block. And then we look, and remember your turn signal theory, and it's built into the presentation here, but you guys are probably familiar with that already. If you're reading 12 lead EKGs, if you're driving your car and you press your turn signal down, you are making a left-hand turn. If you're driving your car and you push your turn signal up, you are making a right-hand turn. And it's the same thing with your bundle branch blocks. Once we locate that J point and back up 0.04, if our terminal velocity is going in a downward direction, it is a left bundle branch block, and that is where our problem comes in. If you do the J point back up 0.04 and it's an upward deflection, that is a right bundle branch block, and you can read that EKG as a normal EKG. And I'm not saying normal that the EKG is normal. I'm saying that you can read it as you normally would. So real quick, this is information, this Sgarbossa's criteria, basically back to like 1996. And when I actually went through class, we were always told that a patient that has a bundle branch block, you cannot read an EKG. You can't read your 12 lead EKG. Just put the machine away. It's not going to do you any good. That is not true. So a lot of people that are out there, especially that went through about the same time I did, were under that impression for a long period of time, and that is just simply not the case. There are ways to do it, but it takes a little bit of practice and honestly probably an application on your phone in order to do that. So here's lead V1, and I'll start with the one on the left. If I find my J point, which is right here, and I back up 0.04, one small block, you can see that the terminal deflection is going up. So the fact that this is going up is a right bundle branch block because my turn signal going up is a turn to the right. If I find the second one here, I find my J point and I back up 0.04, I can see that the terminal velocity is going down. The fact that the terminal velocity is going down, when I press my turn signal down, I am making a left-hand turn. That is a left bundle branch block. So your right bundle branch block in V1, I find my J point. Again, I'm on the EKG diagram. I back up 0.04, one small block. You can see that terminal velocity is going up. I end up having some sort of a blockage. You can see the yellow X somewhere along that right bundle. That is what is causing my problem. The patient can still have their EKG interpreted as you normally would. Don't worry about the right bundle too much, but there is a problem there. The left bundle, on the other hand, if I find my EKG and I go to my J point, I back up 0.04, and it is a negative deflection in V1. That is a left bundle branch block, and you can see that the yellow X has moved from the right, and it is now over onto the left-hand side. So that is a left bundle branch block, and now we have a little bit more work that needs to be done to determine if this is, in fact, an infarction pattern, or if it is a left bundle branch block, or it's just something else that is kind of mimicking that. So the classic pattern of a left bundle branch block in V1 is a QS complex. They don't have an R wave, as you can kind of see in this situation here. There is no R wave going in an upward area. All right, so the bundle branch block recognition, easiest way to do this here is you can either go to V1 or you can just look at your numbers, right? These numbers don't lie to you. What lies to you is the interpretation to the right. If we look at the QRS, what is my QRS in this situation? Is 0.132 seconds. That is greater than 120 milliseconds, or 0.12. So the fact that it is greater than 120, which is what it's going to show on your printout, tells me that it is wide in nature. We are dealing with a patient that has a bundle branch block. If I find my J point in V1 and I back up 0.04, my terminal deflection is going up. It is a right bundle branch block. So in your left anterior fascicle, in your left posterior fascicle, it will give you some different findings. I'm not going to spend a ton of time here. Just under it, we've talked about the axis deviation, left and right axis deviation. If it is a left anterior fascicle block, so it's on the left side, but it's on the front, it's going to end up creating a pathological left axis deviation. If you remember that when we covered that a couple of months back. And if it is a left posterior fascicular block, it will end up creating that right axis deviation. And those are your numbers that are associated with that. So we can talk about that more at another time, but it does have some relevance and correlation between the two. So how do we tell, and I already have kind of answered this a couple different times, but if you look at the QRS in this situation, remember I told you the number is less than 0.12 or 120 milliseconds. This one is obviously way over that. It's 170. Or you can simply look in your lead V1. I find my lead V1, it's clearly too wide. I end up finding my J point. I back up 0.04. It's a negative deflection. And look here, it is a left bundle branch block. So in this situation, what we're going to end up having to do is either call in and say they're having a left or apply the Sgarbossa's criteria to it. How do these people present? Well, the clinical presentation, it may occur in healthy people, but the majority are going to end up having an MI, coronary artery disease. They'll have left ventricular hypertrophy, which is an enlargement of that left ventricle, probably related to hypertension. They may have dilated cardiomyopathy. The problem with the dilated cardiomyopathy, these are your sometimes, and not always, but sometimes athletes that have an undiagnosed dilated cardiomyopathy and they die at a young age on the soccer field or the football field or whatever. They may have hyperkalemia. So we've talked about some of those things in that tall tinted T wave, and they're certainly found in these patient populations as well. The posterior, however, is heart disease, hyperkalemia. They may have acute cor pulmonale. And remember, cor pulmonale is right-sided heart failure. And that's why, and this is because if you remember back, they're going to end up having that right axis deviation. So they're going to end up having cor pulmonale and right-sided heart failure. And then they may end up having myocarditis as well, which is an inflammation of the myocardium. So recognizing an MI with a bundle branch block, we've talked about this. I don't want to beat this horse too much. That left bundle branch block, you can kind of see in these situations which one is which. So here I have discordant and non-discordant ST segments and T waves. And some of these can be a little bit different or difficult to interpret. If we are looking at A here, what people will often do is they'll see these little peaks up here and they will say, oh, it's a bundle branch block. And oftentimes that may be true, but it isn't always the case. You can end up having something called an RR prime, and it may not end up giving you exactly the information that you think. You think that it is a bundle branch block when in fact it is not. And basically the only way that we're going to be able to do that is truly just follow your EKG. And an RR prime, the depolarization is not getting all the way through. So it kind of hangs up for a second and then the message ends up going all the way through. So that is where some of those issues will end up coming in. And then as far as this discordant ST segment and T waves, what they're showing you here is if my we'll call it a QRS, the QRS is up, as my ST segment is up, my T waves are going to be down. So they are discordant. If I have in B, that QRS, if you will, is heading down, I'm going to have a flip T wave and it is going to be up. So discordant ST segments and T waves are always going to be opposite of one another. And this is how we would recognize a myocardial infarction with a bundle branch block. I want to make sure that I mention that because I don't know if I did. So we're not just finding the bundle here. We're actually trying to determine if the patient is in fact having an MI with a bundle branch block. So original Sgarbossa's criteria here, concordant ST elevation greater than 1 millimeter in leads with a positive QRS complex. And then essentially what they do is they end up adding these up, right? If they have that, they would get a score of 5. And anything that has a score greater or equal to 3 is a positive Sgarbossa criteria, which is telling you that the patient is in fact having an MI. So concordant ST depression greater than 1 millimeter in V1 through V3. So if you look here, here's the depression. It's greater than 1 millimeter and it's in V1, V2, and V3. That would give them a score of a 3. And then excessively discordant ST elevation, meaning greater than 5, with a negative QRS complex. So if you're looking here, you can see that I obviously have greater than 5 millimeters of elevation, but I have a predominantly negative QRS complex. That would give them a score of 2. So that alone would not meet criteria for Sgarbossas, and it would not tell you that the person is having an MI. But if you had those other two, number 1 and number 2, with a score of 5 or 3 respectively, then clearly your patient here with a left bundle or being paced is in fact a positive Sgarbossa criteria, and they're having an infarction. So they've changed this a little bit to include something called a modified Sgarbossa, and we'll look at that just briefly. I'll kind of back up here for just 1 second. So I was always under the impression you could never read a left bundle branch block or a paced rhythm in the pre-hospital setting. As I've already told you, simply not the case. You can, you just got to remember the Sgarbossa criteria if you're interested in doing that. I don't think that any of the ER docs are going to give you a hard time if you just say they have a left bundle branch block. And I have specifically asked some of the ER physicians that most of us know how you interpret Sgarbossa criteria. And the ones that I've asked have all told me by using an app. So they have an app on their phone, they pull it out, they look through the app, and they kind of do this algorithm to figure out if the patient does in fact meet Sgarbossa criteria. So even the ER docs aren't real familiar and have committed this to memory, but certainly cardiology would. They would be able to look at this and determine if they meet criteria for that. So does it work? Well, the answer is yes, based on the research that is out there. If we talk about specificity versus sensitivity, so there was a patient that had a total score of 3 or more, reportedly has a 90% specificity in having an MI. So what that means is 90 patients that are not having an MI, so 90 patients that are not, will not have a positive Sgarbossa criteria. And sensitivity and specificity, it always gets really confusing. But basically, if we did 9 out of 10 EKGs, and we would find 9 out of 10 people did not have Sgarbossa criteria if they're not having an MI. So that's good. 10% of the patients would be false positive. So we may have Sgarbossa criteria when in fact they're not infarcting, and that would be a positive finding and a false positive. And then the same concept here applies. So total score of 3 or more reportedly has a 36% sensitivity for diagnosing an MI. So that means of the patients that had an MI and had Sgarbossa criteria, 36% of those were in fact having an MI, which means that 64% that were having an MI did not have Sgarbossa criteria. So again, this is me saying this, but it's basically 50-50. And obviously those numbers are not exact because the numbers are up on the screen. But if you just kind of think sometimes it works and sometimes it doesn't. But if you're one of those people that like to take things to the next level, then certainly give it a shot. Pacemakers and 12 leads, just a concept here. If you have a pacemaker that is inserted into the right ventricle, it will end up giving your patient a left bundle branch block appearance. And if you have a patient that has a pacemaker wire that has been inserted into the left ventricle, it is going to end up giving a right bundle branch block appearance. They used to always put the pacemaker wires in the same spot. They do not do that anymore. So they will do it based on golf swing, handedness. So if you're right-handed versus left-handed, what is going to be most comfortable for the patient? So if you have a patient that you think might have a pacemaker, ask them where it's inserted. And then obviously the opposite is probably what you're going to end up finding on your EKG when you do that. The most useful criteria from Sgarbossas to determine ischemia. has a low sensitivity. So like I said, even less than 50-50 early, but a 50-50 shot. So excessively discordant ST elevation, so meaning like the opposite, right? Part up and part down, elevation in greater than 5 millimeters is not characteristic. So remember, it has to be that 3 or above, and that would only give you a score of 2. So this is basically looking at that ST segment elevation and determining if it is greater than 5 millimeters and you have that negative QRS complex. But that alone would not meet criteria for Sgarbossas. The modified Sgarbossas criteria is a concordant ST elevation in greater than 1 millimeter in any lead. So they've kind of reduced this a little bit, which actually creates or captures more patients that may end up having MI from this. So in concordant ST segment depression of greater than 1 millimeter. So it doesn't always have to be up, it can be down as well. So, but what you're looking for here is greater than 1 millimeter, which is not new. That's what we've been doing all along. And then there's a pretty small study that was done where they looked at some of this, and this is where this modified Sgarbossas criteria has come from. As I've already mentioned, it's kind of gee whiz knowledge, and it's nice to know if you're an EKG guru or you really are interested in like reading about this stuff. I just wanted to more put this on your radar that the information is there. And people do use it. They may use it in the ED and certainly in cardiology, but there is a possibility to read through your EKG. So does it work? 99% specificity and 80% sensitivity for diagnosing an MI. And this is with the modified Sgarbossas criteria. So the information is, it actually looks like it's a little bit better. And it is going to include patients a little bit more. So 99% of people that are having an MI, that are not having an MI, did not have a modified Sgarbossas. So only 1% false positive, which is better than the 10% of false positives that we had with the original Sgarbossas criteria that has been out for since 1996. So as far as practice, it's kind of hard to do these obviously over the internet here through a Zoom. But if you look at this, you can clearly appreciate that there's probably a bundle branch block. If we look in V1, it is obviously wide. If you find your J point, you back up. This is a left bundle branch block, which tells me that I have to apply modified Sgarbossas criteria to it. So then we're going to end up having to look at the other things. So again, I don't want to beat this horse. I don't know that a lot of people are probably going to use Sgarbossas or modified Sgarbossas. If you do, congratulations and good for you for doing that, but just understand that the resources are there, that you can look it up and hopefully determine if it's a paced rhythm or if it's a true left bundle branch block. And if so, if they're in fact having an infarction along with that. And then here's another example. You can see, obviously, this is wide. I find my J point, I back up 0.04, and that is a positive deflection there. So this would end up being a right bundle branch block, in which case we should be able to kind of read through that material. Another example here, left bundle branch block. If I look at my QRS, the QRS is 188. So 188 milliseconds, we know that that is obviously too big. The other thing that I think this may end up doing, we would have to measure it up, is you may look at that initially and think that it is left ventricular hypertrophy. But remember, patients that are having left bundle branch blocks, all bets are off. You can't call LVH, you can't call it an MI until you go through some of the other diagnostic criteria to figure out if it is in fact a left bundle or if there's something else going on with your patient.